Good morning, and thank you very much, Ken, for the nice introduction. I would like to thank the Dean, the department chairs, and the faculty here at the Arnold School of Public Health for having selected me for this honor to present the Weinberg Lecture this year. I have to confess that this is my first visit to the beautiful city of Columbia and to this school, and I'm really impressed by the amount of work and the quality of work that is going on in public health research. So I have been invited to give a talk on this broad issue of environmental health, and my own work, as Ken said, is mainly in the field of cancer epidemiology. So I would present, a sort of review of some of the major issues in terms of epidemiological research on environmental cancer, but many of the issues are relevant to other areas of epidemiology research and public health research. So I'll be happy to expand on a number of other tracks, if you think that, this is important also. So there is we are in the middle, and we are still facing a big epidemic in terms of the number of cancer cases and cancer deaths that are occurring in this country and worldwide. These are the global estimates in millions of cases and millions of deaths, which have been produced by the World Health Organization for 2012. 8 million deaths and 14 million new cases of cancer. But what is more important is that this is keep increasing, and the estimates for 2012, the projections are in the order of 17 million new cases of cancer and 10 million of deaths. So what are the causes? Just one important aspect here is that the increase is mainly taking place in countries with low resources. I divided here the number of cancer. These are just for men, I think, but it's just to give an idea. High-income countries and low and medium-income countries, the number of cancer deaths for in 2002 and 2012, sorry, there is a mistake here, it's 2012, comparing the increase, and as you see that there is still the number of cancer deaths is increasing in high-income countries, US, Europe, Australia, Japan, etc. But the largest number, the large increase is taking place in the order of 3% per year, which is very large in low and medium-income countries that have limited resources to face the cancer epidemic in terms of treatment, and therefore prevention becomes even more important in those countries. So there are really three components that explain this large increase and the switch in the cancer burden from what used to be considered the main area for cancer, which are the developed countries, to low and medium income countries. There are three components. One is the growth of the population, and the second is the aging of the population. Cancer, as many other chronic diseases, and by and large, these considerations also apply to many other chronic diseases, cardiovascular disease, neurodegenerative disease, chronic respiratory disease, etc. So the growth of the population, the aging of the population, being cancer, most cancers have a strong age dependence in their incidence and mortality. And then there is a third component, which is probably the most interesting one, which is the changes in the pattern of risk factor for cancer, and switching from sort of traditional lifestyle and traditional habits into a sort of a more industrialized and urban environments with changes in many aspects, including changes in environmental and occupational risk factors. This is just to give an idea. This is the world population in 2005, the estimate in 2009, in 2030. The point is not only the overall increase, but is mainly, and this is familiar with everybody who has been working on global health issues or whatever, not only the overall increase, but the shift in the distribution with a much bigger increase in the number of people in middle age and old age compared to the past. I mean, so these are the people who are going to develop more and more cancer and other chronic diseases. And if we go into a bit more detail, I just want to present one example of this contribution of the different components to the risk of cancer and to the future, at least in terms of projections. We can be wrong. Obviously projections are always difficult to do in a very precise way, but at least gives a sort of a framework, on how to look at this problem. The example that I chose is an easy one, which is lung cancer, because it's mainly driven by one particular risk factor, which is tobacco smoking. I choose China because we have relatively good data, and obviously the population is very large and it contributes a lot to the overall cancer burden. So these are in green are the number of cancer deaths that are occurring in China today. Obviously, these are estimates because we don't know the number precisely, but they're reasonably estimated. And the yellow bars are the estimates in 2030 if just taking into account the aging and the growth of the population. So just the demographic change in the population. What is interesting in cancer, in lung cancer, is that, as you said, we know, based on the experience in many other countries, that it is mainly driven by the tobacco consumption, with some latency of about 20 years or so. And we are all familiar with the data from the American Cancer Society on the epidemic of lung cancer and tobacco smoking in the US. So what we did in this particular case was to use the example of one of the countries that had the most mature epidemic of tobacco-related lung cancer, which was Scotland, because in the UK the epidemic started even earlier than in the US, and now we see really the whole story going through. So what we did in this exercise was to use the experience of Scotland, in particular among men, to predict what may happen in China if China goes to follow the same pattern. So basically what we did was to say, well, today the rate of lung cancer in Chinese men is about 40 per 100,000, and this was the rate in Scotland at some point during the increase, during the part of the epidemic for lung cancer, which was still very much an increase. What will happen 20 years from now if China would follow the same experience as what we have seen in Scotland, but US would be the same, etc. Well, in fact, in 20 years, there will be the top of the epidemic. It will be in the order of maybe 80 per 100,000, the rate of lung cancer, because this is what we have been seeing in many other countries. Well, if you factor in this change in rate, not just the change in the structure of the population, but the increase in the actual risk of cancer because of this epidemic of tobacco-related lung cancer, we obviously see we predict a much bigger increase in the number of lung cancers. So basically, we factor in this shift from the rate that we see today to the rate that we may expect to see in 20 years or so. So now, whether this will happen, we don't know, and obviously we hope that it will not happen. We hope, in other words, that the Chinese experience will not follow the Scottish or the US or the UK or whatever experience, but this is what we can sort of foresee based on what we know in terms of past trends that can be used for predicting future trends. So this is just to give an idea of how important these three components, aging of the population, growth of the population, but changes in the risk factor, and I just use one example, are to determining the epidemic and the rates of lung cancer. So, what do we know in terms of the causes of cancer? A few years ago, I've been involved in a systematic review of the causes of cancer in France, and then we applied the same approach to a number of other countries, in particular some of the newly developed countries like China, Brazil, but also Korea and Japan. And when you really try to distill what is known and what are the important causes of human cancer, one comes down with about 10 groups of causes. And I know that some people may disagree on some details. I mean, there is obviously a lot of areas where the evidence is a little bit unclear, but basically we have obviously some cancer that are genetics. Then we have some of the major causes of cancer that has been known for some time, although, for example, in the case of chronic infection, we have been learning a lot in the last 20 years or so with many important infectious causes of cancer that has been identified. The whole area of diet, including weight and physical activity, and I know that this is a particular area of very strong research going on here in the Arno School. And then there are a few other areas, including in particular occupational environmental factors, where we know quite a lot about it. When people try to do estimate of the contribution of these combined causes, and possibly their interactions, etc., there has been a number of exercises done in different countries, including the one we did, as I said, in a few countries, and we come up with this estimate of about half to two-thirds of cancer that are attributable to this constellation of causes of cancer, these different risk factors. So we still don't know quite a bit in terms of the etiology and the causes of cancer at the population level. And if you think there are important cancers, I don't know how many of you are familiar with I'm just going a little bit more into the detail, but there are a number of important cancers that we know very little in terms of environmental or known genetic factors. Prostate cancer is probably the most striking example. It's a very important cancer, second most common in men, and yet we know a number of genes that explain a little bit, maybe 5-10%, and beyond that we know very little about the possible contribution of these causes to prostate cancer. And this is despite a lot of work, a lot of studies in epidemiology and clinical, etc. Now, let's focus now on the issue of environment and cancer. And there are basically, environment, many of you are working on a department of environmental health, so I don't need to tell you, but basically it has a sort of, it's a sort of broad definition of environment, and we need to really understand what we are talking about. This is the dictionary definition, which includes, obviously, a number of sort of factors that may affect living organisms, in particular may cause disease, but also cultural and social factors that also are influencing disease. So this sort of broad definition is reflected, I think, in the use of public health, because there are at least two ways in which environment is used when we talk about environmental health or cancer or whatever. On the one hand, people sometimes talk about environmental factors when we talk about everything which is not genetic, everything that is modifiable, including diet, including infectious disease, including all these other factors that I showed before in terms of possible risk of cancer. And for example, when people talk about gene-environment interaction, that's the way often this is used, including gene-tobacco interaction, gene-alcohol interaction, or whatever. On the other hand, we obviously have in mind this more restricted way to think about environment, which is all the all factors that are part of the external media that we have really little control about, or whatever we want to define it. And this includes air pollutants, water pollutants, soil, food, etc. And in fact, I will concentrate on this more narrow definition of environment, although, as I said, I will be happy to discuss it in a broader sense. When we did our estimate of the role of the known risk factors in shaping the burden of cancer in France, and I said I've been involved in some other projects in other countries, we ended up with, these 10 or so causes, and the overall estimate was about 50%, 40% or whatever in men. And in fact, as you see here, the contribution of environmental factors in the narrow sense was considered to be very small, and I will discuss this more in detail now. But this is clearly, we didn't include air pollution at that time, and I will come back to this, but this reflects, our sort of partial understanding of the causes of cancer, and the very fact that we came up with a relatively small overall proportion of cancer attributable to the different causes is another example of that. So what are the established environmental causes of cancer in this more narrow way? as Ken Moon said, I've been working for a few years, for about 20 years, in fact, at the International Agency for Research on Cancer, and IARC has a sort of compilation of known causes of human cancer, known and suspected and possible causes of human cancer. For those of you who are familiar with this, it's called the IARC monograph evaluations, and in particular, these evaluations have a list of agents that are put in what is called Group 1, and these are the sort of the established human carcinogens. When we look at the environmental factors in this list, it comes up to a relatively short list. As you see here, it's ambient air pollution, a number of components that are mainly important under the general rubric of indoor air pollution, radon, and secondhand tobacco smoke, indoor air pollution from coal burning, and then asbestos and a few other similar fibers. And then one water pollutant, which is arsenic. There are a few suspected environmental causes of cancer, and I will come to this in a minute. I will describe briefly these 5 or 6 environmental causes of cancer. So for illustrating mainly some of the methodological issues, I think. So, outdoor air pollution. A major issue that, most of what we know in terms of outdoor air pollution is based on agents that are not carcinogenic per se, like sulfuric and nitric oxides. And most of the data available from historical, which may be used, to reconstruct exposure in epidemiological studies, are based on these pollutants that are not only not carcinogens per se, but they are also usually poorly correlated with important factors. So try to use those data to understand the strength of the association and dose response or whatever usually don't work very well. There has been more focused in the recent studies on fine particles, in particular PM2.5, but the amount of good quality prospective studies which have data on PM2.5 is limited, and we will see them in a minute. The other important issue, I think, for outdoor air pollution study is that exposure assessment is mainly at the ecological level, which introduces, as you well know, exposure misclassification, which tend to attenuate associations, at least under some circumstances. The ability to distinguish the contribution of specific components of air pollution is limited, and diesel has been probably the one which has been driven the most attention, but again, it's very difficult to really have good data on the contribution of diesel exhaust, for example, in the total air pollution. Then there are obviously important issues in these epidemiological studies, like the contribution of occupation. Oftentimes, people living in the most polluted areas of cities or whatever tend to have also the most heavily exposed jobs to lung carcinogens and other factor that may be confounders related to social class. So it's really one of the major challenges to disentangle these different contributions. Again, it's nothing new for epidemiology, but it's particularly important and illustrates some of the issues. So these are the key studies on PM2.5 and lung cancer, which has been used in a recent IARC evaluation for air pollution to be classified as human carcinogens. Well, obviously, we don't need to go into the detail of all these studies, just to show that, the number of lung cancer was not large, except in this last European pooled analysis. This is a pooled analysis of 14 different studies. These are the risk estimates, relative risk in terms of the slope of the dose response for per a given increase in the exposure to PM2.5. For example, the relative risk was 2.2 in this study of no smokers. These were done in 6 areas of, this is 6 areas. This was done in a group of no smokers in California. So for a 24.3 microgram per cubic meter increase in 2.5, the relative risk was 2.3. And you see there are some heterogeneity in the risk estimates. However, these studies tend to show maybe a 5 to 10% increase per 5 to 10 microgram cubic meter, which is quite a bit, is a strong association. However, one important aspect I want to show to you, and we'll come back to this, is that for some of these studies, there was the exposure was basically based on the residence in a given period of time, and were linked, with some pollution data from that period. And sometimes the period of exposure overlaps with the period of follow-up, which is the period here. So, for example, in the CPS2 study, the average pollutant level used for assessment of exposure was in the early 80s, and this was also the time when follow-up started. And we know that, we need to have some latency between exposure and disease for cancer. And therefore, from a qualitative point of view, hazard, whether there is a risk or not, is probably good enough, because the groups that were highly exposed in the 80s were probably also highly exposed in the 60s. From a quantitative viewpoint, however, there are more issues, I think. So when people apply these estimates, and this has been using the American Cancer Society estimate of a risk of 1.08 per 10 microgram, when people applied it to some scenarios of exposure, this was a study done in France, looking at 2 particular cities, it came up with a pretty high proportion of total lung cancer that are attributable to this air pollution. For example, in Paris, the average PM2.5 was 18, and this was done from a study in the early 90s, which would correspond to about 13% of total cancer, which are attributable to cancer. And 13% reflects of lung cancer reflects about 2% of total cancer. So it will be quite a sizable proportion. As I said, the use of recent exposure data is a little bit problematic, in my opinion, because it tends to overestimate the dose-risk relationship. I mean, if we underestimate your exposure level because you use recent data, although the cancer were caused by past exposure 20 years earlier when the levels were higher, if you underestimate your exposure level, you overestimate your dose response. I hope this is clear. And in fact, in the CPS2, in the paper by Pope, with Dan Krusky, Michael Toon, etc., they did some sensitivity analysis, and when they used more recent data, they found, much lower. When they used older data, they found much lower risk estimated compared when they used more recent data, which makes sense, because obviously the lower your exposure data, the higher the risk estimate. So again, there is little doubt that higher pollution causes lung cancer. How much and what the dose-response relationship is a bit problematic. And this is another issue to consider. This, again, was a nice paper published a few years ago in the Environmental Perspective by the same group of people using CPS2, the American Cancer Society data. This is a dose response for very high level of PM2.5 exposure, which is based on smoking, basically. Just try to quantify the amount of PM2.5 from smoking. And then here is the extrapolation at low dose with the 2 estimates from the air pollution studies. And you see that, both tend to be a bit higher, not quite a bit, because in fact it's about 3 times higher compared to the sort of linear dose response that you would expect by fitting the smoking data down to the very low level. So there is uncertainty here, and there is some suggestion that some of the estimate may need to be recalibrated or whatever. And then obviously there is the issue of potential residual compounding. So that's for air pollution. I move quickly to some of the other lung carcinogens, again, mainly to illustrate, the issues and problems, etc. This is radon, which is quite important and probably not so well studied. I think the best evidence comes from a pooled analysis of 13 studies which were done, in fact, in Europe, where traditionally the work on radon has been probably more detailed than in other parts of the world. This was done by Sarah Darby from Oxford, now about 10 years ago. And they came up with this dose response, when they pooled all the individual data. That's a very nice example of the power of pooling individual level data into sort of large, not really meta-analysis, but meta-analysis of individual records. And their estimate was in a relative risk of, again, 1.08, excess risk of 8%, per an increase of 100 becquerel per cubic meter, which is pretty large because, in fact, for example, in France, and again, we use it to estimate our French study, the average exposure on the population level is 54 becquerel per cubic meter, but still, it means that about 4% of total lung cancer may be due to radon. One advantage of radon is that exposure tends to be relatively stable. It depends obviously where people live, so it depends how good the residential data are in epidemiological studies, how much migration there is, how long people live in their houses, etc. But by and large, the exposure in a given setting remains relatively stable. And well, this was another example of how informative this combined analysis can be. They stratified their results by age and found, for example, no effect in young people. I hope, this, you can read this forest plot. It's just the relative risk and the confidence interval for the different categories. Another interesting result is that there is no association with squamous cell carcinoma of the lung. Maybe we go into too much detail, but lung cancer is made of 4 major histological types, and there are growing evidence that the etiology may be different. And the strongest effect is for small cell carcinoma, which is not very common. It's about 15% of total lung cancer, but is the most aggressive and the most lethal form of the disease. Second-hand tobacco smoke, there have been many studies, about 50 case control studies, about 10 core studies. When we did our estimate of the attributable fraction from France, we used basically data from some of the large studies, some of which I was involved in also myself. And we came up, with the estimate of the order of 5 to 10%, mainly for women, obviously, because the number of women exposed to secondhand smoke is higher, at least in the past, because there were more men smoking, so it was more common for a no-smoking woman to be married with a smoking man than the other way around. And this was the estimate of the relative risk, the proportion of exposed. I don't think we need to go into much detail, but these are the proportion of lung cancer in never smokers. We did not consider smokers because the contribution of secondhand smoke in smokers is very difficult to estimate. And we will apply this attributable fraction for both workplace and household residential exposure. We came up with this sort of 10 to 20% of lung cancer in never smokers due to environmental tobacco smoke. This fortunately is from the past. Nowadays, exposure to secondhand smoke has decreased dramatically. Less and less people smoke. Most workplaces are smoke-free, so hopefully this is sort of disappearing now. What is interesting is less known, at least for people not involved in global cancer epidemiology, is the importance of other sources of indoor air pollution. In particular, the whole issue of using coal under circumstances of poor ventilation of high exposure. And in fact, there has been a number of studies done mainly in East Asia, in China and Taiwan. And this is a recent meta-analysis done by Dan Hosgood, who is now at Einstein in New York, showing that the overall relative risk for women, this mainly no-smoking women from China, for women living exposed to high level of indoor air pollution from, and we will discuss in a minute what it means, is in the order of twofold. And in fact, there were some suggestion that, if you really restrict to never smokers, it's even higher, although most of the women are never smokers. And there is some very nice examples of how important this indoor air pollution may be, or may have been at least in the past. This is a study done in this area, a series of studies done in this area, Shuangwei, in the Yunnan province of China, where in the 70s there were these extremely high rates of mortality from lung cancer, both in men and women. 20 per 100,000 was about, as you see here, about 3.5-fold for men and almost 10-fold higher than the average for China in women. And this was really due to the high level of indoor pollution from use of smoky coal under unvented pit. And the interesting thing is that, this result stimulated an intervention to remove and to replace stoves and to increase the ventilation system into the house. And in fact, there were some environmental studies showing that, you know, with the improvement in the ventilation and the change in the type of, you know, equipment that was used, the level of exposure to particulate and to benzopyrene, one of the major carcinogens, decreased amazingly. And there has been now results from cohort study, and these are some of the examples of this exposure. There is, for example, a study of 21,000 residents in this area. 80% of them changed to the new improved situation, and you see that the relative risk now, with about 20 years follow-up from the changes in the late 70s, 25 years, there has been about half, the relative risk is about 0.5. I mean, there has been halving of the risk of lung cancer. And you see here, these are the people, men and women, who remained with the poor ventilator and the one with the changes. I mean, and there was this major change. And by the way, there has been some interesting molecular epidemiology studies done in these populations where they show that the pattern of mutation in P53 for the women exposed to the smoky coal was very similar to the pattern that is found in smokers, with a high proportion of this type of mutation, which is a G2T transversions, which is not common in never smokers, and again, it's not common in Asian women, which are not exposed to the high level of pollution, while it's extremely common in this group of lung cancer in this group of women with high exposure. So there is a sort of fingerprint of heavy indoor air pollution from coal burning, which is comparable to the one found in smoking. Just a few, just going quickly, asbestos exposure. There are a few studies looking at environmental non-occupational exposure to asbestos. Obviously, the asbestos is a major problem in terms of occupational exposure, and we are still looking at the legacy, you know, of this effect. There are still probably a few cancers, in particular mesothelioma, that are due to non-occupational exposure to asbestos. These are some of the meta-analyses that we did a few years ago. There were 7 studies on mesothelioma from household and residential exposure, with a relative risk overall in the order of 3 or 4. And there are not very good data on how many people may be exposed to asbestos at these sort of levels that may cause an increase in mesothelioma. But overall, there are probably a few cases that are due to asbestos. Anyway, when we put all this together, we came up with these numbers in the project from France, without taking outdoor air pollution, as I said, into account. And you see that we came up with a relatively small proportion, maybe 1 or a bit more than 1% of total cancer, although the number will increase if we add air pollution. We said it will probably go to 3 or 4%. And the largest contribution, at least in our assessment, was due to radon. Whether this is true or whether this is due to the fact that radon is easier to measure and we have better data, we have more precise relative risk, etc., that's really a big question. And maybe a lot of what we don't know very much about in terms of environmental cancer is because of limitation of epidemiology. There are a few other causes that are highly suspected. I have no time to go through all of them, just mention a couple. There is the interesting story that chlorination byproducts of chlorination water may cause cancer, in particular bladder cancer. And obviously there has been a lot of work done on organic chemicals in particular that are present in the environment and how can be the contribution to cancer, and I just mentioned a few here. In terms of water chlorination byproduct, I think is fairly convincing in my opinion. I mean, there are a number of studies, and there is a nice meta-analysis. In fact, it's a pooled analysis of primary data published now about 10 years ago by the group in Spain, in Barcelona, showing, you know, quite not a very strong association, but quite consistent association of the order 1.2 for bladder cancer, for high level for an increase, for high level, I mean, more than 1 microgram liter of 3-halomethane, which is this group of, you know, chemicals formed by chlorination. And when we try to apply it to the French population, again, as part of our French project, we came up with about 3% of bladder cancer that may be due to exposure to chlorination. In this case, obviously, we are facing the dilemma, which is very common in public health, of risk versus benefit. I mean, the benefit of water chlorination are enormous. Whether we should consider using other ways for other approaches for water disinfection because of this possible health effect in terms of bladder cancer is something to consider. In terms of organic pollutants, this is probably the most difficult area, at least in my opinion, which have been confronted. Evidence for a cancer risk comes from occupational studies. We know that a number of occupational groups are exposed to high level of dioxin, solvents, etc., and there is strong evidence for several associations. However, when we look at the effect in environmental type of exposures, the data are much less clear. And again, it may be due to a limitation of epidemiology. So the big issue is how much we can use epidemiology to estimate those risks and how much we want to go with model and extrapolations, etc. For example, one good example, I think, is dioxin. These are the risk of cancer in one of the important population that has been studied over the years for environmental exposure. These are people from a city in northern Italy called Seveso. Probably some of you who have been working on dioxin know these studies, which have been exposed in 1976 to an industrial accident. And in fact, these people had pretty high level, and a number of people developed chloracne, which is an indicator of high level of exposure. Yet, now we have data with about 30-year follow-up in terms of cancer, and there is very, very little evidence that there is an increase in cancer. The standardized incidence ratio compared to the sort of the regional population is a little bit below 1 for those for the sort of the broader area with very little exposure, and for the one with the highest exposure, the one we had high proportion of chloracne, high level of dioxin in blood, etc., the relative risk for cancer is in the order 1.0 whatever, is below 1.1, and with very wide confidence interval. So the evidence, for example, for this population that there is an epidemic of cancer due to the industrial accident is limited. Okay, so I'm sort of wrapping up. Estimate of the contribution of environmental cause of cancer. What we know, as I said, most of the estimates are in this small range, maybe 1%, maybe 4%, or whatever, but in that range. And there are important factors for which we know relatively little. As I said, the whole area of indoor air pollution is, we glance a few things, but we don't have a full picture. Contamination of drinking water, for example, by arsenic is important in many settings, and in fact in some populations this is an important cause of cancer. In Bangladesh, northern Chile, Taiwan, etc. There are areas, I didn't have time to discuss it, but that's a very fascinating area where environmental exposure to asbestos is important, where there are major contamination of the ground, of the material used for building material, for example, that are contaminated by asbestos or similar fibers like erionite. And there are areas where epidemics of mesothelioma have been described, like in Cappadocia in central Turkey, in another area of Yunnan in China. So, how to deal with the limitations of our knowledge? I went quickly and tried to describe, some of the limitations. Obviously, we need to improve our epidemiological studies. I see 3 areas to improve. One is to do larger studies where because we need to identify smaller risk, probably. You remember the graph, for example, for outdoor air pollution and lung cancer compared with smoking. We are looking at much, much lower exposure. And there is now more and more work done to try to combine the data and to create, consortia and network of collaborators to work, on similar projects to improve, the precision of our study. Improving exposure assessment is really the main issue, and I will have a next slide on that. And sort of related to this is try to use more biomarkers of exposure and effect. And probably some of you are familiar with this idea of trying to integrate exposure across life, which is sometimes called the exposome approach, which would be try really to integrate both the external exposures and the sort of the internal markers of possible carcinogens like, inflammatory markers, lipid peroxidation markers, etc., and the microbiome, etc., into one sort of multiplex type of measurement of many different, factors together. That's a nice idea. There's been a few examples, a few attempts to do it, for example, apply to the enhanced data, etc. I see it more like a framework. Whether, how far we can move in this direction, obviously, is a major challenge that we face today. These are some of the areas for priority, in my opinion. I mean, the fact that we really need to look for different time windows of exposure. And there is now more and more interest in the possibility to look at cohorts of children, to look at exposure to environmental factors throughout, life, in particular early life. Well, I discussed this a little bit. And there is a whole issue of what happens when people are exposed to more than one agent. That's extremely difficult to study in epidemiology because of the numbers, but at least it can be done in some sort of modeling type of form. And there is some work now that starts to be done there. And obviously there is the issue of genetic susceptibility. So, in conclusion, for many environmental pollutants, we have relatively poor epidemiology data. We glimpse something, there are some signals, but we are far from having a very strong, consistent evidence that allows us to quantify, to understand, etc. This is not a reason for preventing public health activities, and oftentimes the same agents are also important for non-cancer outcomes. So this obviously is a purely, but my considerations are in terms of research and not in terms of need for intervention and for. But I think we should use this really to understand the limit of our current knowledge and where we can do better. There are a lot of challenges, and I try to describe some of them, jumping from one area to the other. Having said that, I think I remain convinced that, studying environmental causes of cancer remains a high priority, not only because it's something that I do, at least part of my work, but because there are a number of other important considerations. This is an involuntary exposure. So in a sense, there is more, I think there is a higher level of moral obligation to study something for which people are, well, one should study everything, but in a way the fact that people may be exposed without knowing it, or without choosing it, gives, to me, a particular flavor to this issue. And importantly, we know how to prevent it. And in fact, there has been a lot of examples. Asbestos is a good example. Clearly exposure to asbestos in the population at large has diminished a lot, given the, still is still present, is still important to study, but is much lower than in many other, that it was in the past. And also the fact that, as I briefly said, but it would be important, it would be nice to expand on this. What we learn and what we understand in terms of environmental causes of cancer is applicable, is relevant in many instances to other chronic diseases. So these are the people who have been helping me working on these issues and think about this. The late Professor Toubiana from Paris, who was the initiator of this project in France, and then a number of colleagues, including Ken, which have been, sort of working over the last few years. Thank you very much for your attention.